Let's veer away from that, shall we, for a moment, because this is one of the critical things we always see in academic medicine. We've got MS clinical trials, right? We've got all the literature, we have the peer-reviewed stuff. And then we've got out there men and women trying to treat MS. So how do the outcomes used in the clinical trials translate to what people actually see in clinical practice?
Yeah, so you know, as you've heard already from Clyde and from Pat, we look at relapses or clinical attacks. We look at MRI activity, new lesions, enhancement on occurrence.
This is with gadolinium, right?
Gadolinium, which is indicative of a breakdown of blood-brain barrier, meaning there's essentially an inflammatory process going on in a focus in the nervous system. And we look at various measures of neurologic function based on the classic neurologic physical examination, but also some tools that have been developed to assess how well people function, such as how fast they walk over a 25-foot course, how well they're able to put pegs into a board, kind of like a cribbage board.
Yeah.
And
you do realize that by saying cribbage, you have so dated yourself.
yeah, right. Well, I played cribbage in the 50s and 60s, okay, in summer camp.
How's your horseless carriage doing?
In summer camp, I learned how to play cribbage. And various tools at looking at cognition and more recently vision testing, low contrast vision testing, in an effort to use various ways of looking at a patient and see how they're doing. In a clinical trial, we do this in a very standardized and quantitative fashion as much as we can, and as objectively as we can by having what we call blinded evaluators doing the testing or supervising the process, so that they're not aware whether the patient in the trial is receiving an active treatment or a placebo treatment. But in clinical practice, it's quite difficult to do this kind of standardized quantitative testing on every patient at every.
I was going to ask you that. I mean, it's one thing.
And every visit.
It's one thing to get a report back from the MRI, right? Because here it is. I was going to say in black and white, but that's dated too. It's somewhere on silicon and popping up on a screen. But when you're clinically in the office, there are the expanded disability status scale. You alluded to that, right? And there's also the multiple sclerosis functional composite. Do people actually run these things? Do you sit down? Do you do that in your office?
Well, I would say that for clinical trials, the EDSS is just a way of quantifying that
That's
thorough,
the disability scale.
The disability scale, that thorough neurologic exam that I think we all intend to do and try and do, but it's a way of quantifying it. I don't always quantify it out when I'm doing the exam, but I'm trying to hit all of those points, as I think most neurologists do. But I think it's paying attention to the nuances, which is the lesson from the clinical trials. If someone changes even a little bit on their neurological exam, they didn't have numbness in a leg before, but now they do. They didn't have an upgoing toe Babinski sign at one point in time, and in follow-up they do. That would move the EDSS, and that should move us to think that they're not actually doing well.
You'll forgive me.
Please.
The words little bit and going from no Babinski to a Babinski, that to me is big.
Well, it's big to us, but that's not something that a patient, of course, is ever going to tell you. You don't know it unless you look for it. And so, this is why we tell
patients took home at night and scratched the soles of their feet?
Some of them do.
Do they really?
Actually, but that's a separate issue. I mean, I think the other lesson from the clinical trials for us in practice is what our tolerance is for disease activity. Mm-hmm. So when we look at the outcomes on relapse rate in the clinical trials, as Pat said earlier, they used to be a lot higher back in the old days, but now the relapse rates in pivotal trials in the modern era are 0.3, 0.18. This is one relapse every 3 years, one relapse every 6 years. So if a patient on a drug has a relapse, it's too many, because it hasn't been 3 years, it hasn't been 6 years. In all likelihood, it's too many.
I just want to give you a personal observation. I have never seen neurologists this excited in my life. Because in the past, neurologists have come by to my ICU, here's the diagnosis, have fun. And now it's, here's a diagnosis, we can do something about it. That must be a real buzz.
Well, again, that's why MS is so exciting, that we can, particularly for those of us who diagnosed patients before the disease-modifying therapy era, you can now really have a meaningful impact in salvaging an individual's life. It's very exciting.
That's neat.
Yeah.
There's an antique term, but it is neat. And so what we have is all these treatments. And the trick, it seems to me, is to be able to differentiate among all of them. And there's a lot of them out there. And I know there's head-to-head trials. I'm not going to name them all, but there's the Avonex versus beta-furon, and beta-furon, Avonex, and Rebif or Rebif. There's the interferon beta-1b versus glatiramer acetate, and the Transform study. There's just a lot of them. So how do you go about parsing all of this out, Steve?
Well, I think part of the reason why we emphasize the direct head-to-head trials is because I think the truest thing that we can say about our trials in general is we can't compare the results across trials. We can't compare the efficacy of one drug in one trial with a different drug in a different trial. And so the head-to-head ones give us a little bit of a window of insight that all the other trials don't. And so the ones you mentioned, I think, are important in that regard.
But it certainly wasn't an inclusive list. I don't want our viewers to think that I just named every trial that's out there. It goes on.
Right, and that's been important for us. I think you mentioned the interferon, some of the interferon comparison trials. So I'm of the belief, based on those trials, that the high-dose, high-frequency interferons are more efficacious on preventing relapses than the lower-dose, once-weekly interferon. And I take that to be a true statement, and it informs how I choose these medicines for patients. In previous years, if someone were on a low-dose weekly interferon and they had breakthrough disease, I might switch them to a high-dose, high-frequency interferon. It's only because we have so many other options now that I think that that's become an almost old-school way of approaching this, because we have newer medicines. But I think those trials demonstrate the utility of that strategy even in the modern era.
You all do the same thing? How do you go about picking an agent? What makes you decide on one versus another? Somebody jump in.
So I think that brings up a very important point. We're using multiple factors. We have 10 agents. None dominate the field for very good reason. You're having multiple factors that you consider that include drug factors, and efficacy is important, and that's where head-to-head trials can be valuable, because they give you some evidence-based value to saying one seems stronger than the other. But it's also, what are the side effects? What are the tolerability? How quickly does the drug work? Then patient factors. What is the patient expectation? They have to take the medication. You could have the best drug in the world, and if the patient isn't going to take it, it's useless. What are their expectations? What are their comorbidities?
That, by the way, is something lost on residents from time immemorial. I gave him this drug, and he didn't get better. Does he still have any pills left? Yeah, pretty much all of them.
And then disease factors, because I think when we're initiating and making recommendations about the optimal therapy, you want to know, what is the baseline disease activity? Is this a very active patient or not? What is their prognostic profile? If you have a bad prognostic profile and you have very active disease, then efficacy may be very important. If that's not the case, then maybe that's not the most significant feature.
Well, we have new mechanisms.